my initial thought was in terms of just the overall flow, is that of
Mm-hmm.
course, yes, any complaint into the upper extremity, you will screen out the spine first, of
Mm-hmm.
course. My next thought was, okay, well, from then, once the spine is done, then I don't care if the complaint's in the wrist, I'm going to screen out their shoulder. And then once the
Mm-hmm.
shoulder's done, I'm going to go to their elbow.
Ah,
And then once the elbow's done, then I'm going to finally get to the wrist.
I see.
And you're saying, no, that's not exactly the case. It's if the person has the wrist complaint, yes, screen out the spine. And then in the categorization of the symptoms and the syndrome, if you
Mm-hmm.
feel like the shoulder is a major player because of the particular syndrome, then yes, centrate their shoulder and see what that does to their wrist.
Mm-hmm.
But if you don't feel like the shoulder is particularly involved, then you go directly to the wrist and manage the symptoms based on, based on the symptom kind of presentation, based on the syndrome that you're thinking
Yes,
is going on. And
that's right.
once the local symptoms have been brought down and desensitized, now you go back and you say, okay, we are going to retrain function of the upper quarter. And that involves making sure that the shoulder, the spherical joint, is centrated and that all the major muscles around that joint
Mm,
are at least patent. And that's when you get
that's
into
right.
the local manual
That's right.
muscle tests.
That's right.
Okay.
This
Okay.
is the same for the upper and lower extremity.
Right.
So
Right.
the knowledge of syndromes, the knowledge of the systems, and that's why I tell people, I said, go to internal medicine books, go to orthopedic books, and find out how do dysfunctional systems represent themselves in the musculoskeletal complex. You must know if the spleen refers to the shoulder. You must know where the kidneys refer. You must know all these things. You don't have to know them in great detail, but they must be in the background of your mind
I was going
as
to say
shad.
that it must be in the back of your head that is,
Yes, they must be shadows that can come forward and remind you of the interconnectedness of what is being presented by the person in front of you, so that you do not miss anything. And so, when you have done this, you must make sure that the systems are back online that are, and sometimes it is not easy because you may have an older person who has comorbidities where the
right.
systems are already in significant trouble. And
Yeah.
you will have to choose how much you think you can do, what is realistic, and where can you find resources that can compensate for this system's inability to be restored to 100%. That is really the art now of going, what else could help do this without becoming overloaded too soon? So, for instance, I have a patient with knee pain. He sent to me because he can only walk a block, if that, without without the knee seizing up. Well, the list of problems that he has are significant. So if I were to
General,
just
what's the
start
age of this patient?
in his probably over 70,
Okay. I
so
like this already. I like to hear you struggling, having to deal with a mid 70-year-old with a lot of comorbidity. It's
that's
not,
right.
one of the major players in the dance company that we're dealing with here.
That's right. It's not your easy walk in, no. But it could
Tell me about
be,
it.
yeah. And I have women, men who come in who are older and have comorbidities. And you have to then be prepared to look at them and go, first of all, I just can't sit down and start giving him deep breathing and bracing. He'll go, what? I know I came in for my knee, and
Right.
my knee's so bad and is so urgent that you have to find out what is wrong with the knee. Because if I
Right.
don't, he probably won't come back.
Yeah.
So
Right.
my job then is to go, okay, let's examine this knee. Let's look at the posture of it. What is it suffering from? What are the most likely things it's suffering from? And from that, I try the first aid. It is like the Mackenzie. You go, well, can it bend? Has it got a direction of preference? What are the structures that really cause the pain? And by doing that, you can say, well, in the hour I have, I'm going to try and find out what structures are most painful, what system they belong to. Can I bring down their irritation or irritability? And can I give this person something to try to see if it will make a difference by the subsequent visit? And that throws out the order of
Right.
wedging them on day one, and so because it's not going to work, it's not going to work.
Screening the spine and all the rest.
That's right. So you go, this person is functioning at a certain level. So whatever is wrong already. My job is to make it less wrong. It's not to right the wrongs immediately. It is to make it less, to see if I can even make it less wrong. Because if I can make it less wrong, I have an in.
Yeah, there you have a chance.
That's right. Then I have a chance. And now I can go, okay, let's diverge and make sure you can breathe deeply and well into this area and that. But that is the first thing is the relationship. Can I affect this at all? And can I make him less wrong? Because a lot of things are wrong. So if you come from that, then you will spend that time wisely trying to see relationships. Is this from his hip or is it local to the knee? Does his foot ankle look like it's a major player in what is going on in the knee? And then you go, okay, I would like you to do some simple either stretches or exercises to see if we can make this less wrong, because that will be my in. And once you have done that, now you start adding, you go back to the algorithm and you go, okay, I think with this under control, I can go back and start cleaning up the other things that I've seen to the best of my ability, and let that algorithm join up with the localized treatment that you are trying to use to make that area less irritable. So there's a flexibility that is born of looking for what will make this person more functioning. Mm-hmm. And can I bring down the effects of this acute or chronic morbidity symptoms that have brought him to me? Yes. Because, the person may say, well, yes, I'm seeing my cardiologist. I have a stent in here. I have this, that. I've been cut open 3 times. Well, yeah, if you go, okay, let's start with you in 3-month position, they'll probably walk out. I would too. I go, what is wrong with you?
I mean, it is. I mean, yeah. And that's kind of analogous in terms of the pediatric approach.
Mm-hmm.
It's, in DNS, of course, we're stressing ideal, and we're stressing the idea that you don't want to place the infant or child into positions they can't get to on their own.
Mm-hmm.
But if you have, a more severe neurologic pediatric patient, you can't just simply never sit them upright, even though they can't do it on their own. That can't happen. There is a practical, all right, we understand you don't have great stability, but we're still going to sit you on a ball, put your hand here, and attempt to get you to lift your head and do things, even though it's not ideal, because they have to function.
Yes, and the important thing is to know that you are out of sequence, and therefore what you are expecting is different. You are not a slave to the exercise because you know that it doesn't really belong in the sequence, but it is needed at this time. And that is a very different level of understanding than just randomly assigning exercises that are out of sequence and you're not even aware that it's
Yeah,
out
you
of
have
sequence.
right.
If you enjoyed
Well,
this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.